Thanks, Cindy, for that kind introduction and for being able to pronounce Faculty of Medical Leadership and Management, because I still stumble over it and people call us Fulham or something. I know, but it really is a great privilege and pleasure to be here. I guess you probably don't think it's terribly special, the fact that you're all here, but the fact that so many students so early in your careers are interested in these major issues of the day is so different to what life was like when I was a student, which all seemed to centre around being very silly and getting drunk, and major issues of the day sort of escaped us. So thank you very much, and thank you for your interest. I'm normally very anxious speaking in public, but it sort of has paled into insignificance tonight because this is my college, and anybody who has got the fellowship of the Royal College of Surgeons, and certainly when I did it, will know that as you walk into that marble area hall at the front there, that's where you get the results for your fellowship exam. And I hope things are slightly different now. But what used to happen in my day is you were given a number. So it's actually quite a privilege for me to be in this building and referred to by name rather than just number 321. You can see 35 years ago, and it's still emblazoned on my memory. And you come in, and when you've done all these sort of tough exams and so forth, and you get your results, and you stand in that hallway, and the guy, I think he's the Beadle, stands with some sort of fancy stick, and reads out, and used to read out your number of the people who passed. So you sort of, you waited for your number to come up, and if your number didn't come up, you just sort of turned around and disappeared. So I have to say, it sort of still sends a shiver down my spine. Tonight's topic sends an even bigger shiver down my spine, and I hope that some of the things that we'll talk about tonight, and I hope some of the solutions, if you agree with them, will stay with you for the whole of your professional lives. Because we've plumbed some depths in the NHS which I never hoped that we would see. And what I want to do tonight is to talk a little bit about some of those in the Francis report. But this is my key message. I'm 60 on Friday, I'm sure you don't believe that, but so I'm getting quite interested in how kind you're going to be when I finally truck up into your care, which maybe soon, I hope not, but that's nothing to do with you. But there are some really serious things in the Francis report, and what I want to do tonight is perhaps slightly get underneath it and move past the sort of the shock horror, and hopefully stimulate some debate, because what I'm going to do is give you my views on things, and I don't know whether I'm right or not, but I hope at least it makes for an interesting discussion. The Francis report, there are two Francis reports, the first one on the left-hand side, second on the right. What Francis did initially was, in broad terms, was to describe what went on in the Mid-Staffs Foundation Trust, which I suspect many of you have at least picked up sound bites from the press. And on the right-hand side, he was asked to then look at the systems issues that actually allowed that to happen in our very proud NHS. And what I'd like you to do now is just do something sort of slightly strange for me. I'd just like you to shut your eyes. And I'd just like you to think that, let's pick an example, you've bust your leg, and you've just been admitted to hospital, and you're bedbound, so you can't get out of bed. And let's say halfway through the afternoon you get that rather unpleasant rumbling in your stomach which suggests that you're just about to develop diarrhoea. And normally you would leap out and go to the loo, but you can't. So you press the nursing buzzer and nobody comes. And it gets more and more urgent, and eventually you can hold on no longer and you have profuse diarrhoea in the bed. Just think about how you might feel if that happened to you. And just feel what happens, because an hour later and you're still lying in it, and 2 hours later you're still lying in it, and 3 hours later, and 4 hours later, and so on and so forth. That's the sort of thing that happened in Mid-Staffs. Okay, and if you don't believe me, and I'm going to do what is always regarded as fairly poor practice in talks. I'm going to read you some stuff because it's really, really important. This is one person that gave evidence to the Francis report. Mum was in bed, she hadn't got a stitch of clothing on. she would have been horrified. She was completely naked, and if I said covered in feces, she was. It was everywhere. It was in her hair, her eyes, her nails, her hands, and all of the cot sides. It was literally everywhere, and it was dry. Pretty horrific stuff, isn't it? Got two quotes now which start to make you wonder what on earth was really going on. I think they were aware that their jobs were near impossible to do to the standard they wanted to do them. But I think it had been an incremental thing where things had become harder and harder and harder, and they didn't actually realise just how far off acceptable standards things had slipped to. And I don't think that any of them would have let that happen if it had happened overnight. I think they would have been up in arms, but I think it was just so gradual they didn't recognise it. And I have to say, I have seen this in my professional career, where you get so numb to the same thing happening day in, day out. I'm sure psychologists could explain to you what happens. But this is, I think, the start of beginning to understand how, I think, probably very caring people, I suspect some of them weren't, but I suspect most of them were, but how very caring people can start to do some pretty hideous things. And then it goes on, where care was less than it should have been. There was never through a desire to provide that level of care, rather sheer lack of numbers to provide it. And I unreservedly apologise, etc., etc. But hands-on care requires that, enough hands. We didn't have enough hands. In my time I'm mid-staffs, I saw numerous examples of selfless devotion on the part of staff, and so it goes on. So if you think that this was just a hospital that all the psychopaths went to work in, just purely by chance, these were possibly people like you and I. And therefore I think we all have to examine our conscience and think, are there circumstances where we could behave like this? So, if you're anything like me, I think this could be a bit of a confusing picture, that on the one hand, we've got clear accounts of hideous things happening, and on the other hand, people actually were there at the time saying, well, actually there were examples where there were very caring people. And I think one of the issues that we face is that this, for me, is the sort of standard reaction that we're very good at in this country, and maybe the Western world, maybe the whole world, I don't know. The first thing is everybody goes shock horror. Then we have a witch hunt. Self-righteous individuals have a field day, and often those people are people that have not been directly affected or anywhere near the process. The press makes loads of money, and wherever there's misery, there's a rich lawyer. And the reaction of the system, if you're in the health services, we produce an action plan, and for me, nothing changes. But why does nothing change? Well, I think because the minute you get into expressions of shame and apologies, I just wonder whether this isn't a cop-out. Because, I mean, I could be standing here now and saying, this is horrific, this is shocking, and all this, but that might make me go away feeling slightly better, but it actually doesn't sort anything out. So I think there is comfort in the platitudes. I think there are sectors of our community, and I think the politicians might fall into this trap over the Francis report, which is to deflect blame. So let's talk about everybody else except our responsibility in this. And then I think there's a feeling very much that this is the sort of thing that they do. This is not the sort of things that I do or goes on in my organisation. I think this leads to very limited and confused ownership of the problem. You then get thousands of simplistic views of what the issue was, and if you look at Francis, some people are saying it's all because of David Nicholson, the chief executive of the NHS. Some people are saying it's because of boards, some people are saying it's because of nurses, etc., etc. Well, actually, it isn't any one of those, it's the whole lot, and probably much more besides. And then at the end, we get simplistic solutions to what is a very systemic problem. And so the fundamental belief I have around this is that it is the NHS culture which has to change, and I think we should take our focus now off mid-staffs, we should use mid-staffs as an example. But there's also something where I think we've got to probably have a much more honest dialogue with the public, or I think it always sounds very patronising to say we must educate the public. But when you look at literally 2 to 3 weeks after Francis reported and talked about mortality data and so on and so forth being unacceptable, the data from Leeds Paediatric Cardiac Surgery Unit was called into question. And suddenly, having on the one hand said, shock horror, they've allowed the hospital to carry on working when mortality rates were high, and then when somebody raises the question about mortality rates in another organisation, everybody says shock horror and Sir Bruce Keogh should resign. Well, you sort of can't have it both ways. But what went on in Leeds is a bit like you saying, I've just seen a crack in that bridge which I hadn't seen before, and people say, well, we'll just carry on driving over it because actually we'd rather like that bridge. You would never accept that. I want to talk to you a little bit now about some theory which I think is really important, and that links leadership with results. Because you'll hear leadership talked about a lot, and I guess many of you will start to develop an interest, I hope, in leadership. But the point of leadership is actually to get results. But what we have to remember, and the bigger the organisation or the team you're in, you have to remember this particularly, is that it isn't a direct relationship. There are very few leaders who just say, this is what's going to happen on every hour of and every minute of every day and in every location everywhere, which is part of their domain. What happens, the only way that leadership really can function, is that you create a climate. And it's the climate that then allows, and if it's a positive climate, allows people to get on and do good things and then get results. And just to show you two simple graphs that relate leadership to outcome in the health service. This is the work of a guy called Michael West, who one of my heroes. What Michael West showed is that if you have good team working in your organisation, if you look at the top left-hand side there, then you'll have lower mortality. And I'd ask you whether there was good team working going on in mid-staffs or whether you've seen good team working in your practice. And one of the things that you will, I suspect, hear is people say, well, actually, all you're about is being really good technical doctors, and all this leadership and teamwork and that sort of thing is all pink and fluffy, and is an optional extra. That slide on the left-hand side there would suggest that these so-called, which I don't think they are, but so-called softer skills are every bit as important as being clever with tablets and good with sharp instruments. If you look at the bottom right-hand corner, you might imagine that you could understand how frontline teams and what they do can link to mortality. The bottom right-hand corner says if you have good leadership in your executive team, i.e. the chief executives and the people that run these organisations, then if you have good leadership there, you'll have fewer patient complaints. So there's something that goes on in the boardroom that tracks right the way down to what patients experience. And I think mid-staffs is another great example of that. So one of the take-home messages that I'd like you to go away with is the way you behave not only has an impact on the experience that people have, but it actually has an impact on the hard outcomes that we measure that patients experience on a day-to-day basis. So how does that work? I found this is just one study that I found a little while back. Some of you will be aware there's a big department store in North America called Sears that were going down the plug hole financially, and somebody came along and did the usual turnaround thing. And then somebody very clever, they said, we've done the turnaround stuff, but actually if we don't get the staff engaged and involved, then there is a real danger that we'll just slip back into the same place again. So they did a big engagement study with the staff, and the organisation turned around, and sustainably so. And what was very interesting, when the Harvard Business School came and reviewed it, and by the way, this is not rocket science. I hope you will all sort of be able to identify this. What this shows is they had good leadership in the organisation, which led to better quality inside of the organisation, which staff experienced. The staff were satisfied, and over time the staff became loyal. Loyal staff then gave better value and better productivity to the customers, who over time became satisfied, loyal, and the growth and profitability was an end product of that. Now just picture yourself on a good day, and just imagine now that you're working, say, in a hospital, and somebody treats you really, really well, and they look after you, make sure you're fed and watered properly, make sure that your education is fine, and make sure that all your creature comforts are there. Are you likely to be of a better and more compassionate care to patients than on a day when somebody treats you like dirt and takes away all those creature comforts and abuses you, makes you pay for your car parking, takes the biscuits away, which is the NHS's favourite answer to a financial crisis? It's there's a thing called discretionary effort, and discretionary effort is the difference, is what you can put in minus what you have to put in to keep your job. I just ask you to think about that, and I think the answer is fairly simple. So I think this translates into the health service. I'm very happy to be challenged on that at the end. Well, my organisation now, the Faculty of Medical Leadership and Management, and Rebecca's sitting just over there, can tell you as much about about it as I can. What we've started to do is to try and translate this for the health service and use slightly more health service language. And my big worry in all this is that we actually focus up here, quite rightly, because this is the holy grail that we want to get. We want to get a good experience for patients. But when we see that this goes wrong, one of the reactions is, let's dump on this lot of people down here. And of course, what we really need to do is to treat these people with the same care and compassion that we expect them to deliver to these people up here. And that's another of my, I think, my very simple messages tonight. You're fairly early in your careers, and you may feel like you're on the bottom perch of this. But believe me, life trundles on very quickly, and I would ask you to think 2, 3, 4 years hence, by which time you will all have people who are junior to you. Think about how you're going to behave towards them, because it really matters. The way you behave towards them will impact on the way that they behave towards patients. I was going to personalise this and to take the sort of the gender bias out of this, but my wife said it is only the men that need to change, so I thought I'd do. And then to do what Cindy asked me to do, to try and paraphrase a report that has 290 recommendations. I'm afraid I've ducked that one, but Peter's going to tell you each one in great detail. But these were the things that Francis talked about. So fundamental standards and measures of compliance. So we need to be measuring what we're doing. We need to have basic standards. Well, actually, I would argue we need to have very high standards and not drop below the high standards. Requirement for openness, transparency and candour, and I guess you may talk about this. We just had a very interesting conversation around this, because I think it's complex, but my experience certainly is the more open you are and honest you are with patients, they are staggeringly, wonderfully tolerant of what goes on, which is not something we should abuse. But I have to say, it always makes me feel much more comfortable as a clinician to have been entirely honest with the patient. The next one, compassionate care and committed nursing, is a bit mother of an apple pie, because it's not just nurses, it's every one of us. And the final thing there, which is my bias because of the organisation I'm in, is that I'm absolutely convinced that good leadership saves lives. So we do need to have good leadership, and that's quite tricky. This is just one of my favourite quotes, but we've really just got to get the data out there and in public. In fact, actually, the patients aren't that interested in the results and data, but it sure as hell doesn't make clinicians compare each other and want to up their game. Recognition, just the bold stuff in bold, and on the left-hand side, the healthcare management leadership is or should be treated as a profession is important. I've been in leadership roles for 20, 25 years and met an awful lot of opposition from my clinical colleagues, as this has not been a respectable profession. I would urge you to see this as every bit as respectable as being good at clinical medicine. And in fact, I would suggest that if you can't lead and manage well, then you're probably not going to be a great clinician. And that was just to say we got a mention too. I've already had a swipe at the lawyers, which is one of my other favourite group of this lot. And just to remind you that actually my generation is not handing you the easiest of things. This is just the slide that shows the size of the bank bailout. You can run the NHS for 5 years on the amount of money we gave those charming individuals who, if we don't continue to give them bonuses that are bigger than your lifetime's earnings on an annual basis, they'll leave the country. To which my reaction is they can bugger off. So just to conclude, what I wanted to say is just some things that I think that you can do. These are very sort of personal comments. The first thing is decide what your values are and be brave enough to stand up for them. It is really difficult, and especially if there are people around you, many of them, and they're more senior to you. But be true to yourself. And at the end of the day, I have met very few people who were brave and stood up for their values that suffered as a consequence of that. We still live in a society where I think we do tend to protect people like that. The second point there is really important. A ward sister, or actually an ITU sister, when I was very early in my career, heard me say to the relatives of a patient in desperate situation. I said, I know how you feel. And she pulled me to one side after, and she said, you don't know how they feel. You'll never know how they feel. And of course that's entirely true. But you have a privileged position as students because people will talk to you. Patients, as an old and grey neurosurgeon, patients are usually terrified of you. So even though you can have a great rapport with them, the stuff they won't tell me, go and sit and listen to their stories. Go and sit and listen to what they really value in what you do. Because very little of it is they assume you're going to be clever and they're going to do the right things. What they value in you is the way that you speak to them, that you treat them, and other things besides. Never be too proud to make a bed, to move the glass of water closer to the person that can't reach it, and so forth, because there are people out there that, you know, that isn't their job, and you will be the better for it, but more importantly, the patients will too. The next point there is, a boss of mine once said to me, you know, Peter, he said, no matter how clever you've been in terms of the surgery you've just done, the only thing the patient sees is the wound, so always put stitches in neatly, which isn't trickery. But actually, if you cobble up a wound and make it look hideous, then they will assume that what you've done inside, or they might assume what you've done inside is hideous. So, you know, and the cleverer you've been, I mean, patients, why should they? They often don't appreciate how clever you've been. And the point, really the final point there is being a good doctor, I am absolutely convinced, is more than just being clever. And this is just one example of how you can make a difference. This was the response that our National Clinical Fellows, who are trainee doctors who are only a few years ahead of you in the system, wrote in response to the Francis report. This has gone around the world. Don Berwick, who's been speaking today, I hear at Excel, who's giving one of our most prestigious annual lectures tomorrow night at the College of Physicians, and who David Cameron's appointed as his sort of, I think he's called, is he called a safety czar or whatever, one of these fancy titles. But even he read this and said this was just beautifully clear. These are people who most people in the system wouldn't regard as having an opinion worth listening to. This is so beautifully succinct, and Rebecca's got copies of it which I think are outside, and I would urge you to read it. So, last couple of slides now. I just ask you, and it's a no-brainer, which system do you want to work in? And I've read the one on the left. The quote by Kenneth Schwartz, who was from the States, but I believe this goes on in this country as well. Yet the ordeal has been punctuated by moments of exquisite compassion. I've been the recipient of an extraordinary array of human and humane responses, and the final comment I've made, the unbearable bearable. And this is not, as I say, you being the most wonderful molecular biologist on the planet. This is you just going and sitting and chatting to somebody, or allaying their anxieties, or spending just a couple of minutes with them. Those moments of kindness make so much difference to people. So my final slide to you, and my advice to you, is yes, be clever. We absolutely need people of your intellect and your ability to be constantly pushing back the frontiers of science. But the second point there is very important, is just be kind. And you might think I've completely gone out saying this, I think, but believe me, this makes such a difference to patients. And the final thing there is sometimes being kind, and sometimes standing up for the values of vulnerable people is not the easiest thing to do, and you will find opposition. So I think on occasions you do have to be brave. And the bit on the slide, the right side is fairly obvious. Never, ever give up. Thank you very much for listening.